I think we will have questions now for both speakers, please. There are some on here, but I encourage people to ask questions from the floor as well. Thank you.
Thank you very much for wonderful talks. I have a question for Dr. Prasad. Dr. Prasad, pardon my ignorance, two questions. As you said, we can have association of monoclonal gammopathy in clots, unprovoked stuff. Do you recommend, or is there a guideline that we do serum protein electrophoresis in a patient who is 50, 60 with unprovoked DVTs and PEs? Would that help?
Excellent question. So essentially, that's based on a few case reports. The Mayo Clinic people are validating that, as far as I understand, and from what I last read about it. So at this stage, I don't recommend looking for paraprotein. I think the unprovoked DVT, as far as I'm concerned, is a very unexplored territory. And what I would do suggest is that if you have an unprovoked DVT, don't do a thrombophilia testing of the inherited variety. So I can definitely say what not to do. But in terms of what to do is an open chapter. And hopefully in a couple of years' time, I'll be able to update you more about that. But yes, it is likely that unprovoked DVT is probably multiple diseases manifesting as unprovoked DVT. It probably could be complement imbalance. It probably could be a paraprotein-related clot. So I don't think we understand that very well. It could be just an activation of DNA nets that we don't understand. So I think at this stage, I wouldn't recommend screening from paraprotein, because most of these people require to have multiple clots, number one, as per current criteria. And the second is the HIT testing, which we do, is a very, I would say it's a very precious test. So having a pre-test of probability and then not loading the lab with that testing would be very important, because otherwise you'll naturally do a paraprotein and do a HIT testing. We are developing a better way of offering HIT testing in a confirmatory environment much more rapidly. So hopefully we should have that up and running by the end of the year. But that's where we are heading. So then we'll be able to explore this further.
Sure. Thank you. Another question. MGUS. Patients are not symptomatic and they don't have any end organ damage. Why are we doing serum protein electrophoresis? Are these patients, are these only this cohort? Do you think they are just the hematological patients because hematology is looking for something else and they've asked for electrophoresis? Why does this term exist for non-hematological patients, and why do we do the testing?
So most of the time when I say they are not symptomatic, if you look at the criteria for diagnosing myeloma, your hemoglobin tends to be less than 100. If you treat a CLL, your hemoglobin tends to be 100. So nobody is doing a EPG in most scenarios where the hemoglobin is 125 and 135. Most of the time it's sitting in that territory between 100 to 115, 120, and people are trying to figure out if there's an alternative explanation for their anemia. That's when it tends to get ordered more. There's certainly no recommendation at the moment to screen for MGUSs. That doesn't exist. It's not cost beneficial, and certainly we do not know what best to do with them. So most of us are moving away from trying to see too many MGUSs regularly.
So there's got to be something on the full blood count, advice from
gets triggered by,
go ahead and do something.
We get referrals for MGUS. We get referrals for MGUS. We rarely actually go and pick up an MGUS ourselves.
Yeah, I think neurologists and nephrologists.
Neurologists, nephrologists, and I'll say, for example, yesterday my colleague got a referral for somebody who had a plasmacytoma 25 years ago. So that can be an isolated manifestation, but as a very small paraprotein. So we are triggers to do a paraprotein testing.
And in your second case, you talked about a nephrologist asked you to look for renal MGUS. So did they do the serum protein electrophoresis, or they just based on the high?
Yeah, no, the patient had a pre-existing paraprotein that we were aware for associated with the CLL. I think I missed that part in my slide. So yeah,
okay. Thank you.
The patient had a pre-existing monoclonal protein.
Yes, like how come just looking at the albumin in the urine, you went said, oh, this patient.
My apologies. The patient had a paraprotein.
All right, thank you.
Also, I think I don't think it was appropriate to try and make the diagnosis without a renal biopsy. So there always has to be.
I just had a phone call and I'm saying people calling in half an hour to say this patient has got NGRS was a bit of a.
Yeah.
Thank you for that excellent talk. In my practice, I tend to see a lot of young strokes. And in young strokes, the thrombophilia screen as a kind of a garden variety thrombophilia screen is one of the kind of recommended investigations, but we don't tend to do any kind of paraproteins or EPG or IPG on these patients at all. Is it now coming to fore that we should be thinking of, especially if you're thinking of MGUS of hematological or thrombocytopenic or neurological significance, that I need to start thinking about these young stroke patients and start thinking about paraproteins in them as well?
So there's a very excellent article in Blood, how to evaluate arterial thrombosis. And essentially the recommendation is not to do inherited thrombophilia testing. So it's extremely rare for us to do inherited thrombophilia testing. The only reason why I would do it is that it's done and nobody else will do it after that. So that's kind of why I would do it in a young stroke. Rarely do you find multiple complex genetic abnormalities. We do recommend testing for antiphospholipid antibody, and that certainly is very important. It's interesting that antiphospholipid antibody syndrome, when it goes haywire, which is called as catastrophic antiphospholipid syndrome, pretty much behaves like what Surya described, which is basically a complement-mediated thrombotic microangiopathy. So it's also thought to be having the same genetic defects as you get in AHUS. And so for us, we would screen for antiphospholipid antibody. Currently in young people, there's no recommendation to screen with paraprotein. The thrombotic significance I've just mentioned, it's an evolving story, and I'm not sure where it'll end up. It's only last year that that case reported it, so it's only 12 months. But in terms of a young stroke and hematology, apart from a full blood count and antiphospholipid antibody syndrome, you can do the thrombophilia testing, but it doesn't change management practice in any way. Yeah.
Thanks. Great talk. I just wanted to ask Dr. Prasad about the MGUS renal variant and multiple myeloma. So I guess we were taught about CRAB back in medical school, and we were taught that if you had renal injury with signs of paraprotein, then it becomes multiple myeloma. How do you differentiate between that and MGUS with renal involvement?
So it's not necessary that when you have paraprotein and you have renal injury, it's always going to be myeloma. So obviously, when we do a bone marrow, we can see the number of plasma cells that could be helpful. Occasionally, we do have to do renal biopsy where you see cast nephropathy. And so and then most of the time when you actually have a significant renal injury, your free light chains are really off the scale. Okay, so we have ways to figure out if this is actually an paraprotein or a myeloma-related renal damage, and the renal physicians are usually very good at teasing that out for us as well. So sometimes the patients have pre-existing bad diabetes, and that may help explain why they've got renal dysfunction. So Surjit may be able to
Also,
answer
just
that
to
better.
add on to that part, so MGRS, remember, they would not have fulfilled the criteria for myeloma, which they would look out for. So the bone marrow may not be supporting, and it's not, I shouldn't say may not be, the bone marrow is actually not supporting a myeloma diagnosis. And yet you have got this unexplained renal failure. And most of the times you're going to get a fair amount of proteinuria in the urine. So background of MGUS, not fulfilling myeloma, and yet you've got an unexplained renal failure. And so you cannot do this diagnosis with the histopathology. It's actually the histopathologist who will call up and tell the renal physician, I think this is MGRS, because I can see that stuff sitting in the kidney. It's not yet fulfilling the criteria for a full-blown myeloma. So which is, I think, it's an evolving field. The way we look at myeloma and MGUS, I think every couple of years it's just expanding. And I think in 10 years' time, the whole thing will become a different ballgame. There'll be so many different things. Like he spoke about skin manifestation of MGUS, and then he spoke about the thrombotic things. I think it's going to be much wider than what we think now.
Yeah, I have seen a patient recently with a monoclonal gammopathy of undetermined significance, with just mild proteinuria, which increased over 6 weeks. And then while we're investigating him for the proteinuria, the C3 was low and C4 was normal. And then we get to have him a renal biopsy. And the renal biopsy confirmed C3 nephritic glomerulonephropathy. And we start to treat the MGUS, and he improved. And I look at the literatures, and I found most of them are C3 deficient. So is it now a standard to check C3, C4 with each MGUS?
Sorry, if I may. With C3GN, you may or may not get low C3 levels in the blood. So I think just the blood level will not give you a diagnosis either way. If it is low, maybe it's pointing, but then C3 could be low in so many other conditions. But it doesn't, I don't think it actually helps you much with the diagnosis. At the end, you need tissue, you need a histopathology. Yeah.
But does this mean that every patient with mild proteinuria and MGUS should go for renal biopsy?
No,
Because there is a treatment now. You can treat the MGUS,
yeah, true.
the patient will recover.
But I think if you've got your usual diabetes and usual hypertension and they are not well controlled, so I'll probably look for those things first. Of course, maybe you'll screen for a myeloma, etc. But mild proteinuria, I'll be careful with exposing them to renal biopsy, unless you said that your patient's proteinuria increased quickly in 6 weeks. Now that's a different ballgame, quickly increasing despite being on ASR, SGLT2 inhibitor. Then I would probably, yes, look for a renal biopsy. So at the end, renal biopsy criteria, there are 3 things you look out for. One is rapidly increasing proteinuria. So if you reach 0.5 gram over 24 hours, yes. But having said 0.5 gram, if somebody comes with 0.4 gram, of course I'll say, okay, it was 0.1 gram 1 month back and now you're 0.4 gram. Of course I'm going to biopsy you. Or an unexplained rise in creatinine, or a sudden deterioration or new appearance of hypertension. So any of those 3 criteria, or dysmorphic RBCs in the urine, we'll go for a renal biopsy, but not for mild proteinuria, which you'll have to exclude other things before you think about it.
No.
Even in the presence of MGUS, because I don't think I have not seen a lot of MGRS. I've seen a few over the years, but not a lot. So I'm not sure whether it'll justify doing a biopsy. But as I said, if there's a sudden, within 6 weeks, there's a substantial increase, which is what you saw, then yes, you couldn't explain it with anything else, then yes, we'll go for a biopsy. But that we will go irrespective of whether there's a background of MGUS or not. If the proteinuria suddenly worsened over 6 weeks, I'll probably say let's do a biopsy.
A question about serum free light chains and the ratio. So if it's mildly abnormal both and the ratio is normal, whether you can reliably exclude.
So if they are both mildly elevated.
But the ratio is within the normal.
Yeah, so generally if they're both mildly elevated, that is usually because of a coexistent renal dysfunction or a inflammatory condition. So I would wait for those 2 situations to settle down. One has to be higher and the ratio have to be abnormal for me to start thinking about something abnormal in practical scenario. So if both are elevated, it generally argues against a clonal process. It more points towards either accumulation because of renal dysfunction or an inflammatory increase.
Yeah. Most of my patients would have both of them off because they are normally renally cleared. But as Ritam pointed out, it's the ratio.
So there's a question here. If a patient has normal paraprotein, well, negative paraprotein, CRAB negative, normal creatinine and ESR, but a mildly high kappa lambda ratio, free light chain ratio between 5 and 15, how do you follow up? So as for Dr. Prasad, obviously, and will you do a bone marrow biopsy, and can you classify this as MGUS? I think you might have covered some of that, but
it's light chain MGUS essentially.
Yeah,
Is that what
exactly.
So it's again similar to the question previously. Is basically they generally are much lesser at a risk of transformation to serious malignancy. So evaluate, and if there are no concerning signs, then just monitor. Probably every 12 months to begin with.
Sounds good. And then, what non-myeloma conditions would you consider with high kappa and lambda levels but normal life chain ratios? I think we've actually covered that one already in a patient with negative paraprotein. That's all I've got here from external. Are there any other questions? Oh, actually, I should leave that. Online or on the floor? Yep. Yep.
So you don't have to beg for an ADAMTS13 assay.
I've got a friend, I didn't have to beg with him.
It is an assay that, at least in Newcastle, we do 24/7 for the entire country. It only takes 35 minutes once the sample hits the lab to get the assay result out. So there's a lot of drama about ADAMTS13, which is not true. So we generally are not averse to doing ADAMTS13, but recently we've been asked to stop providing a 24/7 service, but still you'll be able to get a 24 to 48 hour turnaround time for ADAMTS13. So it's not a big issue. And the second issue is more to Surjit's talk. I think one other thing that we find challenging with AHUS is basically you've got TTP for ADAMTS13, which wasn't there 15, 20 years ago. So TTP was a clinical diagnosis like AHUS. And then you have complement-mediated AHUS and you've got diarrhea-positive AS. And the lack of a diagnostic test for complement-mediated AHUS is a significant clinical issue. And I think that needs to continue to evolve and that needs to be looked into. And I generally don't consider HELP syndrome, preeclampsia and eclampsia to be part of the same spectrum. I think HELP is a completely distinct entity. It is probably more related to AHUS and antiphospholipid antibody syndrome that goes really bad. So I think those 3 need to be separately considered, and there's enough data to show that the same complement genetic imbalance drive those 3 diseases, where eclampsia and preeclampsia have a slightly different genetic profile. So I'll just leave it at that.
So just one more comment before we wrap up. I think if you think, I'm not sure, is it TTP? It doesn't look like a HUS, no history of diarrhea. Also, it's more common in children. So if you've got the classic picture of Coombs negative hemolytic anemia with thrombocytopenia, bit of AKI. So you're stuck between, is it TTP or is it complement mediated TMA, which we also used to call atypical HUS. And the patient is deteriorating in front of you. You still don't have a ADAM TS13. As you said, now it's not a 24-hour service. So I think the plasmic score is quite useful. And have a low threshold for jumping up and making the phone call. So if you think the plasmic score is high, then I think start plasma exchange, speak to your ICU or hematology services, whoever your local service provider is. On the other hand, if it is low, you better start talking about your eculizumab straight away. So make the phone call, start arranging things.
But in neurology here,
Yeah.
to differentiate between both. If the patient has a neurological findings,
Yeah.
Clinically, this will not support TTP.
It would, you're right. So more 60, I think 65 to 70% people with TTP have neurologic features, but having said that, you can get it in the other ones as well. So I think complement mediated TMA, we are seeing a significant number of people have cardiac involvement, and we are waking up to it. And I think even STHUS can present with neurologic findings. So yeah.
All right. Are there any further questions from the floor? Well, I'd just like to thank both speakers for an excellent session. And I think it's probably lunchtime.